Download this code from codegive.com, link in the description below. OK, let's dive into the complex topic of decreased spinal stability, covering its definition, causes, clinical implications, diagnostic approaches, treatment options, and ultimately, how it might be represented, in a very simplified manner, in a programming context. Keep in mind that this is a highly simplified representation for demonstration purposes and should not be used for actual medical diagnosis or treatment. Understanding spinal stability. Spinal stability is the spine's ability to maintain structural integrity, prevent abnormal deformation or slippage between vertebral bodies. Protect neural elements, shield the spinal cord and nerve roots from injury due to excessive motion. Minimize pain and disability, allow for functional activities without exacerbating pain or neurological deficits. Think of the spine as a carefully engineered tower. Stability is crucial for it to withstand external forces, like gravity, lifting, twisting, and internal forces, muscle contractions, without collapsing or causing damage. 2. Defining decreased spinal stability, spinal instability. Decreased spinal stability, often called spinal instability, represents a state where the spine is no longer able to perform the functions listed above. It's a situation where the spine has a compromised ability to resist forces and moments, leading to excessive movement, abnormal motion between vertebrae, often exceeding physiological limits. Potential for progressive deformity, over time, the spine may gradually shift out of alignment. Neurological compromise, compression or irritation of the spinal cord or nerve roots. Chronic pain, persistent and often debilitating pain. 3. Causes of decreased spinal stability. Spinal instability can arise from a variety of factors that affect the structural components of the spine. These components can be categorized into the three-column spine, Dennis's classification. This is a conceptual model often used to understand spinal stability based on how injury affects the anterior, middle, and posterior columns of the vertebrae. Anterior column includes the anterior longitudinal ligament, the anterior 2/3 of the vertebral body, and the anterior intervertebral disc. Primarily responsible for resisting tensile, pulling, forces. Middle column includes the posterior 1/3 of the vertebral body, the posterior part of the intervertebral disc, and the posterior longitudinal ligament, PLL. Resists axial, compressive, forces. Posterior column includes the pedicles, laminae, spinous processes, facet joints, interspinous ligaments, and supraspinous ligament. Resists torsion, twisting, and shear forces. Instability is more likely when two or more columns are disrupted. Specific etiologies. Trauma, fractures, dislocations, and ligamentous injuries due to car accidents, falls, sports injuries, or other traumatic events. Degenerative conditions. Spondylolisthesis. Forward slippage of one vertebra over another, often due to facet joint arthritis or defects in the pars interarticularis. Spinal stenosis. Narrowing of the spinal canal, which can compress the spinal cord and nerve roots. Degenerative disc disease. Breakdown of the intervertebral discs, leading to decreased disc height, altered biomechanics, and increased motion. Facet joint arthropathy. Arthritis of the facet joints, contributing to instability and pain. Infections. Osteomyelitis, bone infection, or discitis, disc infection, can erode vertebral structures and weaken the spine. Tumors primary bone tumors or metastatic cancer can destroy vertebral bone and compromise stability. Inflammatory conditions rheumatoid arthritis, ankylosing spondylitis, and other inflammatory diseases can damage spinal joints and ligaments. Iatrogenic causes complications from spinal surgery, such as laminectomy, removal of the lamina, or discectomy, removal of the disc, can inadvertently destabilize the spine if not properly addressed. Congenital abnormalities birth defects like spina bifida or vertebral segmentation defects can lead to instability. 4. Clinical presentation. The symptoms of spinal instability are varied and depend on the location and severity of the instability, as well as the specific structures affected. Common symptoms include pain low back pain, LBP often chronic, aching, and exacerbated by activity. Neck pain similar to LBP but affecting the neck region. Radicular pain sharp, shooting pain that radiates down the arm or leg, sciatica, due to nerve root compression. Pain that worsens with movement, prolonged sitting or standing, or certain positions. Pain relief with rest or bracing. Neurological symptoms numbness and tingling in the arms, legs, hands, or feet. Weakness in the arms, legs, or feet. Balance problems difficulty with coordination and gait. Bowel or bladder dysfunction in severe cases of spinal cord compression, a medical emergency. Deformity scoliosis abnormal curvature of the spine. Kyphosis excessive rounding of the upper back, hunchback. Spondylolisthesis visible or palpable step-off deformity where one vertebra has slipped forward on another. Muscle spasm involuntary muscle contractions in the back or neck, often in response to pain and instability. Stiffness limited range of motion in the spine. Feeling of giving way or instability a subjective sensation that the spine is unstable or likely to buckle. Diagnostic evaluation. A thorough diagnostic evaluation is crucial to identify the cause and extent of spinal instability. The evaluation typically includes history and physical examination detailed assessment of the patient's symptoms, medical history, and any previous injuries or surgeries. Neurological examination to assess strength, sensation, reflexes, and gait. Palpation of the spine to identify areas of tenderness, muscle spasm, or deformity. Range of motion testing to assess spinal flexibility. Provocative maneuvers to elicit pain or neurological symptoms, example straight leg raise test for sciatica. Imaging studies X-rays to visualize bony structures and detect fractures, dislocations, or deformities. Dynamic, flexion and extension, X-rays can help assess the degree of movement between vertebrae. MRI, magnetic resonance imaging provides detailed images of soft tissues, including the spinal cord, nerve roots, intervertebral discs, and ligaments. MRI is essential for detecting disc herniations, spinal cord compression, and ligamentous injuries. CT scan, computed tomography provides detailed images of bony structures and is useful for evaluating fractures, spinal stenosis, and bone tumors. CT myelogram CT scan combined with injection of contrast dye into the spinal canal to visualize the spinal cord and nerve roots. Used when MRI is contraindicated or when more detailed visualization of the neural elements is needed. Bone scan detects areas of increased bone turnover, which can indicate fractures, infections, or tumors. Electrodiagnostic studies, EMG/NCS electromyography, EMG, and nerve conduction studies, NCS, can help assess the function of nerves and muscles, and can be used to identify nerve root compression or other neurological problems. Provocative discography injection of contrast dye into the intervertebral disc to assess whether it is a source of pain. Controversial and not routinely used. 6. Treatment options. Treatment for spinal instability is tailored to the individual patient and depends on the underlying cause, severity of symptoms, and overall health. Treatment options include non-surgical management pain management over-the-counter pain relievers NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen or naproxen. Prescription pain medications opioids, used with caution due to risk of dependence, or other pain medications. Nerve pain medications gabapentin or pregabalin for radicular pain. Physical therapy strengthening exercises to strengthen the muscles of the back, abdomen, and core, which help to stabilize the spine. Stretching exercises to improve flexibility and range of motion. Postural training to improve posture and body mechanics. Manual therapy techniques such as massage, mobilization, and manipulation to reduce pain and muscle spasm. Bracing external supports, example a back brace or cervical collar, can provide temporary support and limit motion, which can help to reduce pain and promote healing. Injections epidural steroid injections injection of corticosteroids into the epidural space to reduce inflammation and pain around the nerve roots. Facet joint injections injection of corticosteroids into the facet joints to reduce pain and inflammation. Nerve blocks injection of local anesthetic to block pain signals from specific nerves. Lifestyle modifications weight loss if overweight or obese, losing weight can reduce stress on the spine. Smoking cessation smoking impairs blood flow to the spine and can worsen pain and slow healing. Ergonomic adjustments modifying the work environment and activities to reduce stress on the spine. Surgical management Surgical intervention is typically considered when non-surgical treatments have failed to provide adequate relief or when there is significant neurological compromise or progressive deformity. Surgical options include spinal fusion joining two or more vertebrae together with bone graft and hardware, example screws, rods, plates, to eliminate motion at the unstable segment. The goal is to create a solid bony bridge that stabilizes the spine. Decompression removal of bone or other tissue that is compressing the spinal cord or nerve roots, example laminectomy, foraminotomy, discectomy. Often performed in conjunction with spinal fusion. Spinal stabilization with instrumentation using screws, rods, and other implants to stabilize the spine without necessarily fusing the vertebrae. This may be used in cases of trauma or instability where fusion is not desired. Artificial disc replacement replacing a damaged intervertebral disc with an artificial disc that preserves motion at the segment. An alternative to fusion in certain cases of degenerative disc disease. 7. Simplified code representation, illustrative purpose only. Important disclaimer ****. This code is a highly simplified illustration and is not intended for any real-world medical applications. It's designed to demonstrate the concept of how spinal stability might be conceptually represented, not to provide medical advice or diagnosis. Explanation of the code, with major caveats. 1. Spinal segment class represents a single motion segment of the spine. It has attributes for vertebral body integrity, representing the strength of the bone. Disc integrity, representing the health of the intervertebral disc. Ligament integrity, representing the strength of the ligaments connecting the vertebrae. Neural compression, represents the amount of pressure on the spinal cord or nerve roots. 2. Calculate stability score, this method attempts to calculate a very simplified stability score based on the integrity of the spinal components. This is a gross oversimplification. In reality, stability is a complex biomechanical property. 3. Apply force, this method simulates the application of a force to the spinal segment. The force reduces the integrity of the segment based on the direction of the force. This is also a massive simplification. 4. Simulate degeneration, this method simulates gradual degeneration of the spinal segment over time. This is again, extremely simplified. Limitations and why this code is overly simplistic. No complex biomechanics. The code does not account for the complex biomechanical interactions between the vertebrae, discs, ligaments, and muscles. Simplified integrity values. The integrity values are arbitrary and do not reflect real-world measurements. No spinal cord representation. The code does not represent the spinal cord or nerve roots in detail. No individual variations. The code does not account for individual variations in anatomy, physiology, and medical history. Force application is rudimentary. The way force is applied and affects the integrity scores is arbitrary and not based on any real biomechanical model. No muscle involvement, no muscles are involved to stabilize the segment. No complex movement, the spine is capable of much more complex movement than the limited directions specified. No intervertebral effect, this code doesn't consider the effect of movement on adjacent segments. No pain modeling. The code does not attempt to model pain, which is a crucial component of spinal instability. In conclusion, decreased spinal stability is a serious condition that can lead to pain, neurological deficits, and disability. Diagnosis requires a careful history, physical examination, and imaging studies. Treatment options range from conservative measures like physical therapy and pain management to surgical interventions like spinal fusion. While the code example provides a very simplified conceptual overview, it's essential to recognize its limitations. The complexities of spinal stability are vast, and accurate diagnosis and treatment require the expertise of qualified medical professionals. This code is not a substitute for professional medical advice.